Lesotho is a small mountainous country in southern Africa, roughly the size of Maryland, with a population of about 2.3 million. Most people live in rural areas where agriculture is central to daily life. As a developing lower middle income nation, nearly half of the population lives below the poverty line, and youth unemployment is high. Despite an adult literacy rate around 80%, education quality and access vary widely, especially in remote regions. Healthcare access is also limited, with rural communities facing the greatest challenges. Lesotho faces one of the most severe HIV epidemics globally, with an adult prevalence rate of 21.1% as of 2023. While significant progress has been made, over 80% of diagnosed individuals now receive antiretroviral therapy, but barriers still remain, including stigma and limited rural access to care. Lesotho's geographic enclosure by South Africa links its public health outlook to neighboring provinces like Free State, with HIV prevalence rate up to 20%, and KwaZulu-Natal up to 27%, highlighting the importance of cross-border collaboration. The epidemic was first detected in 1986 and escalated rapidly, surpassing 30% by 2001. Although national strategies are included in the early 2000s, large-scale interventions such as PMTCT, ART distribution, and expanded testing only gained traction mid-decade. These developments underscore the need for sustainable, coordinated regional strategies to combat HIV. International support has been pivotal in Lesotho's HIV response. Key milestones include the National Testing Campaign, ART program, and the adoption of WHO's Test and Treat strategy in 2016, which enabled immediate ART initiation after diagnosis. These efforts have led to significant progress. New HIV infections dropped from 30,000 in 2005 to under 7,000 in 2020, and over 270,000 people were on treatment by 2022. Lesotho employs a complex surveillance system that can track prevalence among pregnant women and high-risk groups, such as sex workers, inmates, and men that have sex with men, some of whom show prevalence rates as high as 72%. Community-led strategies, including mobile clinics and home-based testing, extend services to underserved rural areas. However, challenges remain in reaching remote populations and incorporating data from private clinics. Currently, approximately 25.6% of adults aged above 15 are living with HIV, with an annual incidence of 10,000 new cases. Continued improvements of surveillance, prevention, and treatment efforts is essential to controlling the epidemic. Lesotho has one of the highest HIV-related death rates in the Southern African Development Community region, significantly impacting national productivity, increasing poverty, and contributing to a high number of orphans. Compared to regional neighbors, Lesotho's epidemic is particularly severe. HIV prevalence in Lesotho is marked by disparities across gender, age, and population groups. Women are disproportionately affected at 30.4% compared to men at 20.8%, with rates peaking in midlife. Adolescents have the lowest rates, under 6%, but prevalence increases sharply in early adulthood. Urban areas generally report higher rates than rural ones, particularly among women. Key populations mentioned before bear an even greater burden. Among pregnant women, 25.9% test positive at antenatal clinics. These data underscore the urgent need for targeted interventions and sustained prevention, treatment, and care strategies. HIV in Lesotho is primarily driven by heterosexual transmission, gender inequality, and risky sexual behaviors, such as early sexual encounters, multiple partners, and inconsistent condom use. Gender power imbalances are particularly harmful. Young women aged 20 through 24 have an HIV prevalence of 24% compared to just 6% in men of the same age. Socioeconomic vulnerability, especially among women in informal employment, compounds the risk through limited access to health education and care. Biomedical challenges further fuel the epidemic. Many men undergo traditional circumcision without HIV testing or risk reduction education. While access to medical male circumcision remains low, late diagnosis also hinder timely treatment. Lesotho's response has evolved through a combination of behavioral, structural, and biomedical interventions. The national HIV response began in 1987 with the National AIDS Prevention and Control Program. Key turning points include the 2000 declaration of HIV/AIDS as a national disaster, the 2004 Know Your Status campaign, and the rollout of ART starting the same year. By 2006, initiatives like the Rural Health Initiative expanded care into remote areas. Also, between 2011 and 2014, over 36,000 men received voluntary medical male circumcision. These comprehensive efforts, supported by the Global Fund, NGOs, and community campaigns, have significantly expanded testing, treatment, and prevention, contributing to declining infection rates and broad services across Lesotho. Following 2003, Lesotho significantly expanded its PMTCT with ART coverage among pregnant women rising from 58% to 89% by 2012, though it declined to 66% by 2016. The government also increased condom distribution and introduced workplace HIV programs, most notably the ALAFA initiative, which reached nearly 90% of the country's apparel workers with prevention and treatment services by 2009. In 2016, Lesotho became the first sub-Saharan African country to implement the WHO's Test and Treat policy, ensuring immediate ART initiation after diagnosis. This policy led to significant improvements in treatment access and viral suppression. The 2020 HIV Prevention Roadmap introduced 10 priority actions, including targeted youth and male-focused programs. In urban areas, tech-based campaigns have been used to engage youth aged 15 through 24. Lesotho's prevention strategy is comprehensive, spanning national policy, biomedical interventions, workplace outreach, and youth-led initiatives. While this approach suits its generalized epidemic, persistent challenges remain in rural and hard-to-reach areas due to limited infrastructure and healthcare access. Despite progress, Lesotho's HIV response is hindered by persistent stigma, gender inequality, and systematic barriers. As of 2016, nearly 14% of the population expressed discriminatory attitudes toward people living with HIV, contributing to fear, reduced testing, and delayed care. Gender dynamics further restrict women's ability to negotiate safe sex or access services, especially in rural areas where cultural norms and male dominance prevail. Access challenges are compounded by geographic isolation, requiring long travel to clinics that may face drug stockouts, staff shortages, or inadequate equipment. Migration is another major barrier. Nearly 60% of migrant workers default on ART due to uncoordinated cross-border care. Poverty, food insecurity, and comorbidities like tuberculosis and malnutrition further undermine treatment adherence. Additionally, a shortage of health workers and fragmented leadership reduce the effectiveness of care delivery and erode public trust in the health system. Addressing these structural and social challenges is essential to sustaining HIV control and improving long-term outcomes. Lesotho has achieved notable success in HIV prevention and treatment. Initiatives like the ALAFA program demonstrate the effectiveness of targeted partnerships. Similar models could be expanded to high-risk sectors such as mining, transportation, and bordering communities. Local AIDS committees also hold potential for scaling prevention by delivering condoms, PrEP, VMMC, and education within underserved communities. Lesotho has shown strong leadership, which significantly improved ART access and viral suppression. National campaigns such as Know Your Status and community-based testing have all contributed to progress. However, social and structural barriers continue to limit the consistency and reach of these efforts, highlighting the need for sustained and collaborative strategies. Despite significant gains, Lesotho continues to face major challenges in its HIV response. Persistent stigma, gender inequality, healthcare worker shortages, and limited rural access hinder progress. Key populations, such as sex workers, migrants, and men who have sex with men, remain disproportionately affected, with high infection rates and poor linkage to care. These realities underscore that existing strategies, though valuable, must be complemented by strong, tailoring interventions to effectively control the epidemic. To effectively control HIV in Lesotho, we recommend focusing on three key strategies. First, expanding community-based and mobile health services is critical to reach remote and rural populations with accessible HIV testing, prevention, and treatment, supported by trained community health workers and empowered local AIDS committees. Second, strengthening targeted support for youth and key populations is essential, with tailored prevention, digital outreach, and programs addressing gender inequality to reduce vulnerability among young individuals. Finally, normalizing HIV testing and reducing stigma through national campaigns, integrating routine testing into general health care, and training providers in confidential, stigma-free care will encourage more people to know their status and engage in treatment. Together, these strategies can significantly advance HIV prevention and treatment outcomes across Lesotho.